Good afternoon and welcome to our special briefing on the patient value of copay assistance programs and how a CMS rule is likely to harm patients. Hello, everyone. I'm Sally Greenberg, the Executive Director of the National Consumers League, or NCL. Founded in 1899, NCL is the leading national advocacy organization dedicated to promoting and protecting the social and economic interests and justice for consumers and workers in the United States and abroad. You can learn more about our work and programs at nclnet.org. In the next hour, we're going to be hearing from experts about the important role that copay assistance plays for patients. We're going to discuss how the CMS best price rule threatens patient access to these very programs and serves as a roadblock to disease management for vulnerable patient populations. We're going to have an opportunity to engage in a discussion and take questions from our live audience during the latter half of today's program. Before we begin our official program, I want to just thank our live and our on-demand viewers for joining us for today's event and taking the time to understand how we can help protect consumer access to affordable treatments. So on behalf of NCL, I'd also like to thank all of our guest speakers for taking the time out of their very busy schedules to participate in today's program and share their perspectives. Your presenters today include Margaret Scott and Mark Gooding from Avalara, Carl Schmidt of the HIV Hepatitis Policy Institute, and Pam Traxel of the American Cancer Society Cancer Action Network, or ACS-CAN. Before we begin, we want to remind everyone why we are here today. We thought it was really important to get engaged in this issue to protect patient assistance programs for our most vulnerable consumers. When patient out-of-pocket costs go up, treatment adherence goes down, worsening consumer health outcomes and increasing the burden on the overall health care system and on patients in general. As inflation drives up the cost of living, consumers are being crunched by the high cost of prescription medicines. Having higher prescription drug costs disproportionately affects minority communities who are more likely to have higher rates of chronic disease. In fact, according to a CDC report, about 51% of US adults had at least one chronic condition. And those who belong to racial and ethnic minority groups are more likely than white adults to receive a diagnosis of chronic disease in the United States. There is wide bipartisan consensus among patients and caregivers on the need for federal action to require health insurers to count the value of copay assistance toward patients' out-of-pocket costs. So we're going to dig into these issues and explore how a CMS rule disrupts the very consumers that rely on this copay assistance. A few friendly reminders. Our live audience, we're going to begin our official program, but everyone on today's webinar is in listening mode. You can use the chat box feature to submit questions to our speakers throughout the program, but you will be muted throughout. With that, let's get started. To kick off our program today, we've invited Margaret Scott and Mark Gooding to explain what the Medicaid best price rule is and how it's going to affect patient assistance programs. Margaret Scott's an associate principal at Avalara and supports clients on issues related to Medicaid policy and drug pricing. Mark Gooding is a principal at Avalara and provides strategic guidance to life science clients on policy developments and reimbursement considerations. And in particular, Mark has extensive experience analyzing federal and state level policies and developing market access strategies to drive coverage and patient access. Margaret and Mark, thank you so much for joining us.
Thank you, Sally, and thank you everybody for taking the time to join this webinar. Sally mentioned we just want to provide a bit of an overview of really how did we get here and what are some of the programs that we're talking about here. It's a incredibly dense and complex space, and so hopefully over the course of the next 10-15 minutes, we can provide a bit of context around the specific programs that we're talking about, and specifically the risks that this introduces for patients and providers that are looking to get them on, especially medications that they need to treat their condition. So I'm going to hand it over to Mark to really provide a bit of a lay of the land before I then walk us through really, so what are these accumulator and maximizer programs, and we talk then about the VBP rule and really what the so what is for advocacy groups, but also for patients themselves, and what the next steps might look like here. Margaret?
Apologies, I was on mute there. So as Mark said, we'd like to talk a little bit today about the history of copay assistance and a little bit about how we got here with this rule that's coming up. So Mark, if you want to pull up our slides here.
Oh, 1 second, sorry, I thought I was already sharing my screen.
So I can go ahead and get started here while Mark's bringing that up. But we've definitely had significant increases in coverage over the past 10 years or so since the Affordable Care Act was passed. And while the number of uninsured individuals in this country has dropped by about 41% between 2010 and 2016, there's still a significant number of Americans who are uninsured, and those numbers could increase after the COVID-19 pandemic ends, where patients who have been enrolled in Medicaid since the beginning of the pandemic may start to roll off of Medicaid coverage. As of January 2022, over 10 million individuals had signed up for insurance using the healthcare.gov exchange. This is a significant increase from the 8.3 million who signed up for 2021. So hopefully we are working on the, getting rid of the uninsured, that's not the right thing to say, decreasing the uninsured population and making sure that more people have coverage. However, we're seeing increased costs, out-of-pocket costs within that coverage, particularly within the employer market, people who get their insurance through work. Employers have been offering high deductible health plans as a means of limiting the premiums for patients, but lower income individuals who enroll in these plans may experience unaffordable out-of-pocket costs, which of course can limit their access to care. So high deductible health plan enrollment can impact adherence and care management, and is definitely most acutely felt by those enrollees with chronic conditions who have significant costs. In 2021, the average deductible for employer-sponsored insurance for a single individual was nearly $1,700, and that's increased 13% over the last 5 years. And more than a quarter of individuals with employer-sponsored coverage have a maximum out-of-pocket of over $6,000 per year. Median average deductible is almost $3,000, or was almost $3,000 in 2021. So these high out-of-pocket costs have been a challenge for quite some time. And if we can talk a little bit then about the history of copay assistance and the additional scrutiny that these programs have come under over the past several years. So, as I mentioned previously, the increasing out-of-pocket pressures that people have faced, manufacturers and third-party foundations have played an increasing role in providing assistance to patients to support their access and adherence to medications. So if we look at the rise of copay assistance back about 20 years ago, copay support programs were introduced to support patient access. And in 2011, when the Lipitor patent expired, Pfizer actually launched a copay card for the brand Lipitor as the generics entered at a lower price, which many people did not appreciate. Pfizer trying to keep their brand name market share when there were these lower cost generic alternatives. Manufacturer insurance has grown from about $1 billion in 2015 to over $16 billion last year. So huge amounts of assistance coming from manufacturers and foundations. States have been following this for quite a while. Massachusetts, and in 2012, they eliminated their ban on copay coupons. However, they did maintain the ban on products where there was a bioequivalent generic. So that was pretty much in direct response to the Lipitor situation. In 2018, California enacted a law prohibiting manufacturer copay cards. In 2020, Massachusetts extended their law banning that bans the coupons for products with generics. And in the last several years, states have been enacting bans on copay accumulator programs in state regulated health plans. The copay assistance has been under scrutiny for quite a while by payers and PBMs. For example, in 2014, United Healthcare proposed to put a ban on copay cards for their enrollees. This was subsequently retracted, obviously based on stakeholder input. In 2016, Express Scripts criticized the extra cost to the system that they say copay cards introduce to payers and employers based on the idea that it's causing patients to get more brand name drugs and not going with lower cost alternatives. So the growing copay assistance market and cost pressures that consumers are facing and payers are facing have driven new ways to mitigate, payers have started new ways to mitigate their financial risk, which has resulted in the increased use of copay accumulator and maximizer programs. And for exactly what accumulators and maximizers are, I will turn it over to Mark.
Thank you so much, Margaret. I think that's super helpful context, just understanding kind of what is happening in the broader patient affordability market for specialty therapeutics. So I think it's important just maybe to level set on what are these programs we're talking about. We tend to lump them into one group, but it's important to understand the nuance between what these programs are, how they're implemented, and how they affect patients, the patient journey, how they're experiencing the out-of-pocket liability, their ability to fill that first script and to stay on therapy. So we're going to generally talk about what are copay adjustment programs, and that's more or less a umbrella term for copay accumulators and copay maximizers. I think folks tend to lump everything into the accumulator bucket, but we do just want to point out the kind of important distinction between these two types of programs. So on the accumulator front, it's important to note that they are retrospective in manner, essentially a program that identifies if and when a patient uses a third-party copay assistance card, whether that's from a manufacturer or from a foundation, and removes those dollars that are paid by that third party, removes those dollars from the calculation for that member's progress towards their deductible and progress towards their maximum out of pocket. So essentially what happens there, the patient progresses more slowly through their benefit. It takes longer for them to meet their deductible or their maximum out of pocket, which draws down additional funding from that third party source, and may, in certain instances, lead to a situation where the patient has exhausted all funding from that third party source and may find themselves not having yet progressed through their deductible or maximum out of pocket, to their maximum out of pocket threshold, as they might have otherwise done absent an accumulator. Maximizers then, just quickly, are prospective in nature. They require the individual enroll into the program, and what is done here is for a certain selected set of therapies, the PBM or third party will carve out a select set of drugs and communicate with the patient that if you are interested in receiving these products, you'll have a higher co-insurance or out-of-pocket liability unless you enroll into this maximizer program. And by doing so, you will typically see $0 out of pocket. And so while that may represent a short-term win or support access in the immediate term, those dollars that are pulled down from that third-party source as part of this maximizer program again, are not counting towards that member's deductible or out-of-pocket maximum calculations, which means the patient may stay, not move through their benefit in quite the same manner. It's important to note both are implemented with the goal of reducing plan sponsor financial exposure for these patients. It's important to know that this is quite a dynamic space, and I think we're going to allude to perhaps a more recent or very timely update on this front. But it's worth noting that kind of the growth that we've seen in these markets over the past, or in these programs rather, in self-insured and fully insured and even individual markets over the past several years. Accumulators were utilized earlier on, and right now about 80% of plans have the opportunity or capability to implement that retrospective accumulator. It's really in the past couple of years that we've seen a significant growth in the utilization or the ability to implement these maximizer programs, as shown in this graph in the bottom left-hand corner, between 2018 and then the 2020 and 2021 numbers. It's worth noting, why is this happening? Mentioning trying to limit plan exposure, plan sponsor exposure, but it's also worth noting that manufacturers and other foundations, there is a significant amount of funding that is available, and these programs are intended to draw down those funds to, again, offset or limit or mitigate the financial exposure that their plan sponsors would face. Quickly then, where are we seeing these types of programs implemented? 4 broad areas where we typically see, though oftentimes these are overlapping. One is the idea of high-cost specialty drugs. Those products where there's likely to be a broader or greater budget impact for covering or allowing access to specific drugs. There's also going to be those specific drug classes, categories, or therapeutic areas where there is typically a larger or more robust out-of-pocket or copay support program offering for specific therapies. Here we are thinking typically like HIV, HCV, MS, but oral oncolytics as well, where you will see a large a large set of available funds, but then also the need from the patients themselves to draw down those funds. Similar to that and overlapping with that would be the idea of where there are competitive classes. This can be used as kind of a way to incent use of preferred products based on tier placement or coverage status. And then also just the idea that we typically see this on the pharmacy benefit side, as opposed to your medical benefit drugs, where the implementing of these programs into the data communication between pharmacy, specialty pharmacy, and the plan, it's just easier for these PBMs and third-party entities to implement these types of programs. So this is a space where there has been a lot of evolution over the past several years. We're seeing these types of programs move into new therapeutic areas and classes and new insurance markets. And then a series of regulatory updates or developments have then emphasized or exacerbated the risks that these present to these third-party sources for copay assistance, but then also for patients themselves, understanding there might be risk for the availability of these funds. So I'll hand it over to Margaret just to provide a quick update on this.
Thanks, Mark. So the reason that we're here today, after we've heard about copay assistance and the effect of accumulators and maximizers, is because CMS put out a rule or finalized a rule in December 2020, the Medicaid value-based purchasing rule, that provides a new challenge for a manufacturer. It requires manufacturers offering copay assistance to ensure that that copay assistance is being utilized by patients and not accruing to payers or PBMs through these adjustment programs and maximizers. So presently, manufacturer copay assistance and any patient support is excluded from manufacturers' calculations for Medicaid drug rebates. And the Medicaid VBP rule removed those protections, again, when a manufacturer can't ensure the value is passed on to the patient. So CMS has made changes to how manufacturers calculate the prices that factor into their Medicaid rebates, which is the average manufacturer price, or AMP, and best price. This means that manufacturers will pay higher rebates if copay assistance is included in those calculations. And this rule is scheduled to go into effect January 1st of 2023. So Mark, tell us a little bit about what manufacturers may do in this situation.
Right. So we've been working closely with patient advocacy groups, professional societies, and manufacturers and foundations themselves, trying to identify how are there opportunities, or how do these regulatory developments inform the offerings that they are providing to their patients in light of these new regulatory risks. Understanding that there are perhaps untenable or the inability to conduct or perform or deploy copay assistance in the same fashion if this rule is to be were to be implemented on January 1st. Understanding there's a variety of different options or ideas that are being tested or floated by manufacturers and third parties around how copay is provided. There are going to be some, and we've already seen this in market today, where manufacturers are thinking about just revising who has access to this copay assistance, and if there's a revision towards the amount of dollars that are available to patients. Again, understanding that the risk that this VBP rule represents. There is also then the idea of just changing the mode of assistance, moving beyond a standard coupon, which may be the most kind of straightforward approach for copay assistance, and by doing so, really introducing these modes to avoid the risks that are presented by this VBP rule. But at the same time, and I say this for somebody who's seen these type of pilots stood up, understanding that there are disruption in that patient journey, and that just creates additional headwinds to patients accessing and staying on their therapy. And as part of this, then at the far extreme, the idea that these manufacturers may have to or be forced to significantly revise, or even at certain instances or certain branches for certain patients, eliminate copay assistance here. I will say, and this is perhaps a canned line of mine over the past 2 years, or really the past 4 or 5 years since I've been tracking these programs, is that this is an evolving space. And I think this VBP rule that was finalized in 2020 introduced a new risk, but it didn't. Absent this rule, there is a significant risk that these types of programs represent. I think it's worth noting that we are seeing, and perhaps perfect or worse timing, that there's been an update. There is a legal challenge in the DC District Court that was filed last April 2021. This was just recently heard. There were oral arguments just about 2 weeks ago, and apparently, and apologies, having just logged on as news was coming in, that apparently the summary judgment is overturning this rule. And I am not a lawyer. I do not play one on TV, so I can't speak, and I do not want to be responsible. And so this is the idea that this is a situation that is developing genuinely day by day. I would just say, even absent this rule that we're kind of pointing to on this rule, these programs do represent a risk to how patients are able to afford and maintain or stay on their therapy. And so, while this is a very specific rule, I do want to acknowledge that there are concerns or risks just to patient access and patient affordability. So thank you for letting me tap dance on this breaking news. I will hand it over to the team for our next segment.
Hi, everyone. I'm back. This is Sally Greenberg again. Thank you so much, Margaret and Mark, for that very helpful explanation of where we are now. And we had a curveball thrown at us. Very timely decision apparently just came down, summary judgment, which we can get into maybe in the Q&A to understand a little better what happened. But we're going to move on now and introduce Carl Schmidt. Carl is the executive director of the HIV Hepatitis Policy Institute. He has been a national policy advocacy leader in the HIV community for over 20 years. In December of 2019, Carl formed the HIV Hepatitis Policy Institute. This is a group that promotes quality and affordability in healthcare for people living with or at risk of HIV or hepatitis and other serious and chronic health conditions. Carl has expertise in healthcare financing and knows a lot about Medicare and Medicaid and has been a champion voice for patients on issues related to patient affordability, copay assistance, and copay accumulator programs. Carl, thank you so much for being with us today, and I'll turn things over to you.
Thanks, Sally, and good afternoon, everyone. And great news, for today for patients. And let's hope that, this is the final decision. But I agree that, this issue of copay assistance is still on the line and so important for patients. And that's what I'm going to talk about. I've been in the HIV world for over 20 years now, and this is just, I think, like in the DNA of how people afford their prescription drugs, particularly people with HIV, hepatitis, and so many other diseases. This, unfortunately, because of insurance benefit design, and that's what I'm going to talk about, and the cost of the drugs, people really rely on copay assistance from the drug manufacturers. So I apologize. This is the third time, I think, in 2 days I presented not on this issue, but just on cost sharing and the importance of the impact on prescription drugs and patient affordability. So I apologize if people have seen these slides in the last couple of days. I promise I'll try to keep them fresh and new, in the future. But just, looking at out-of-pocket costs for all the different healthcare services that we have. And this is looking at CMS data, national data. And you could see that hospital care is the largest component, around $1.2 trillion. And if the out-of-pocket costs are $36 billion, and if you do the math, that's around 3%. But then if you look at prescription drugs, that's like a third of how much we spend on hospital care. But because of insurance benefit design, we actually end up paying a lot more of the total. 14.5% is what they ask patients to pay. And, it's a wonder why people are complaining about the high cost of drugs. It's really how much you pay at the pharmacy counter. And insurance benefit design is showing or is making you pay a high percentage. I frequently use the experience, when's the last time you went to the emergency room and paid 50% on the list price of that service? But that's what happens with prescription drugs. People, have to pay, and they have to go through a deductible too, and then they have to pay a high co-insurance. So this is, made up of because of high deductibles, but also patient out of cost as well. And speaking of deductibles, this is looking at the qualified health plans, the silver level around the country. And they're going up. I know, there's been a big focus on premiums and how they've gone down, which is really, really helpful. But we want to make sure once people have their insurance, they can use it. And that's what insurance is supposed to be for, and to make sure they can afford it. But frequently you have to go through a deductible, and they're over $5,000 right now in the silver level. And that's an increase of 23% since plan year 18. So this is data that was extracted from the Federal Reserve Board. Kaiser did this work, and they looked at patient affordability of healthcare, not just drugs, but healthcare in total. And they said about a third of single person households with private insurance in 2019 could not pay a $2,000 bill, and half couldn't pay a $6,000 bill. And over 40% of multi-person households can't afford mid-range employer family plan deductible of $4,000. That's what you have to go through first before you can use your insurance. And 61% don't have enough to cover a high range deductible. And they conclude with the average out-of-pocket maximum for single coverage of over $4,200, most households do not have enough liquid assets to meet the typical out-of-pocket maximum. Now, a lot of the patients that I represent and work with, they have chronic conditions, and they have to pay for their drugs at the beginning of the year. They have to go through the high deductible. They have to meet the high co-insurance. So they're met with these large dollar amounts. Also, I would say, although this study came out earlier this year, it was based on last year's data. And I think we all know the economy has really changed with inflation, high gas prices, high food prices, high whatever. So I'm sure that it would be much harder for patients this year to afford their healthcare and their medications. This is looking at the silver plans, and this is Avalier's data, thank you. And looking at the federal exchange plans in California for this year. I just wanted to show you, this is looking at different drug tiers, but look at the non-preferred drug tier and the specialty drug. So many of them use co-insurance instead of, co-pays, which are usually, $50, $100, maybe $150 at most. But more and more of the plans are using co-insurance. You can see here, 45% average, 44% average. That's on the list price of the drug. That doesn't account for rebates. So you can see that, the cost sharing is pretty high. Not only do we have high deductibles, but we have high co-insurance as well. And so this is looking at, this is IQVIA data looking at total out-of-pocket cost sharing that patients are responsible for. It's been pretty constant over the years, but it's last in 2021, it was $79 billion. That's a billion dollars. That's a lot of money. And because of high cost sharing, as it goes up, people unfortunately are abandoning their prescriptions that their providers prescribe. And amazing, this is looking at brand name drugs, new drugs that were prescribed. 81 million drugs were abandoned last year. That's not good. And as the price went up, you can see if it was $250 or more, the cost sharing, 61% of the patients didn't pick up their drugs. That's not good for them. There was a reason why someone prescribed that drug for that person. That's not good for their healthcare, and it's not good for our society as a whole. So in order to better afford, prescription drugs, the drug manufacturers have offered, as you heard, copay assistance. And last year, I have a little different data than what was earlier, but $12 billion. That's a lot of money. And it's, you can see it was a little higher during the peak COVID year of 2020. But it's still, a lot of money for patients to offset their cost. And just imagine the numbers of abandonment and lack of adherence that would occur without that copay assistance. The data, it shows that among commercially insured patients on branded medications, 14% of them use coupons to reduce their out-of-pocket costs. I know, there was a discussion earlier about some of the comments, steering to certain drugs and, generic versus non-generic. I have to say, we don't have generics in HIV, or we don't, are in hepatitis. And if there are, they're not low cost generics, and there's no alternatives. And, every drug, everyone with HIV, it doesn't matter the drug, everyone needs copay assistance. It really amounts to the insurance benefit design that they're in. So my bottom line is, now is not the time to reduce copay assistance. If this rule that we were talking about was implemented, copay assistance, the future would be in jeopardy. Thank God it looks like we're going to miss that. But just the copay assistance is extremely important, and we need to continue it. Thank you.
Thank you, Carl. Lastly, we're going to hear from Pam Traxel, the Senior Vice President for ACS-CAN, the advocacy affiliate of the American Cancer Society. Pam is responsible for helping ACS-CAN develop relationships with companies and individuals to help further the fight against cancer through dynamic partnerships, events, and forums. Pam began her career with ACS-CAN in 2007 and has been integrally involved in helping to establish ACS-CAN as a nationwide advocacy organization that influences and shapes public policy at all levels of government, including such issues as copay accumulators and patient out-of-pocket costs. Pam, take it away.
Thank you so much, Sally. I can't tell you how interesting it's been to have a court rule as we're preparing for our webinar. And so for those of you that know me well, we're going to go a little bit off script here for a second. So what does this court ruling mean? I am not a lawyer. I do not play one on TV, but I do have a phone and I can text people. So what I can tell you is that this summary judgment means that this rule will not go into effect unless the government decides to appeal the ruling of the court. And what this rule does is actually take away this particular requirement that they were placing on manufacturers around the use of their copay assistance. So what does this mean for us as patient advocates? And this builds off actually Carl's last slide. So I want to be, really thoughtful about this. Essentially, what we are asking for patient advocates to really think about is we still have an education to do around explaining why copay assistance is important to our patients and the vital role that that plays in adherence and actual, in the case of cancer patients, their very survival. So I would challenge all of the listeners on the phone to really think about how we can continue to make this case, because this court rule does not get rid of copay accumulators or copay maximizers. We will still be working in coalition with many of you here on the phone to eliminate those and ban those actually at the state level. So I want to talk to you a little bit about the cost of cancer and the role of cost sharing assistance in cancer patients, because I would really ask that many of the groups on the phone think about how they can compile this kind of information for their patient population. I think the one thing this rule showed me is that there are a number of people within the administration that don't necessarily appreciate the role of cost sharing assistance in helping patients thrive through their disease. So here at ACS-CAN, we actually have done some polling work, and I'm really struggling here with sharing my screen, but here we go. So we did some polling work actually in February of this year with 1,800 cancer patients in a project we call Survivor Views. You can find all this data on our website. But to ask cancer patients, how prepared were you for the cost of your cancer care? 64% of the people that we surveyed said they were unprepared for the costs, and an additional 54% said that they were unprepared and didn't have the ability to pay for their costs. So I don't think anybody wakes up and says, oh, I know I'm going to be a cancer patient today and I've put away all this money just in case that happens to me. But what we find is that when patients are unable to afford to pay for their care, they resort to a lot of different strategies to afford their care, including increasing their credit card limit and debt. So that's 39%. 39% put off vacations or major household purchases. 28% use most of their savings. 25%, so think about this, 1 in 4 made a significant change to their way of life. As you look down this list, to me, it's a little shocking as to how high these percentages are. When we think about it even further and asked patients, how concerned were you about your ability to pay costs related to your cancer care? Nearly 73% said they were either very or somewhat concerned about the ability to pay for their cancer care. Keep in mind, this is at a time when they're fighting for their very life, and they're really thinking predominantly about how they can afford their care. Then when we dig into this even further, what were their biggest costs, and what were their biggest worries around cost? Services not covered by their insurance was our number one thing. Unexpected medical bills. I know a lot of you have worked on surprise billing with us, and we appreciate that. Incurring medical debt as a result of costs. These are some very large numbers. Then when we think again about medical debt in particular, for this cohort, 51% had incurred medical debt. And this number is 62% among the African Americans that we surveyed in this data. To me, these numbers are pretty shocking. What I found even more shocking, though, was this data, which shows the impact of cancer debt on your credit. So nearly 53% of our survey had been contacted by collections. 46% had had their credit score impacted, and 16% considered filing for bankruptcy. These numbers are even higher among the African American people that participated in our survey. I think this data is pretty shocking. When we look at the cancer debt and what it means in terms of seeking care, 45% of our folks said that they were more likely to avoid care simply because of cost. That's obviously not the environment that we want to think about. More importantly, I think it's critical that we work together to really compile with researchers information about the role of cost sharing assistance in helping ameliorate these costs. So I just want to highlight a couple really important surveys and research that's been done. So there was a study done among ALK inhibitors. So this is a drug that you can take for non-small cell lung cancer that actually improves patient survival. Patients who use cost-sharing assistance were on average 88% less likely to abandon their prescriptions at the pharmacy, 24% less likely to discontinue treatment, and 90% more likely to begin their treatment sooner. This is very important in a disease like cancer, where sometimes days and weeks can make a big, big difference. We also find that cost-sharing assistance was associated with almost a 24% lower annual out-of-pocket cost for the patient, increasing medical utilization, and overall improving key health outcomes. This is across all diseases, actually, so that was kind of exciting data. And then last but not least, I'd like to end with this slide, courtesy of IQVIA. For those of you on the phone who are saying, oh, I never really thought about cost sharing, there aren't really coupons in my space, I don't really know that much about that, I really want to draw your attention to these graphs. The key thing that you need to take away from this is that increasingly, all patients are using savings programs to offset these costs, right? And that's why you see these lines trending up from 2015 to 2020 across all kinds of disease states. So if this is not an issue that you and your group have focused on, I think this IQVIA data would say that it is very important that you think about how you can focus on this going forward. So with that, Sally, I turn it back to you.
Sorry about that. Thank you so much, Pam. We're going to turn to some questions. I think I'd like to start, if possible, to a discussion of this decision that's come down. I am a lawyer. I don't play one on TV, but it sounds like a summary judgment decision is a pretty definitive determination by a judge that this rule has to be halted, at least for the time being. I'm sure there'll be appeals. Is there any of our experts have additional information that we might be able to share with our webinar participants today?
Well, Sally, I didn't read it very carefully. I looked at it just now for a second, but I think just in layman's terms, I wanted to put what this rule did, or what they wanted to do, just so everyone understands. It's all because of copay accumulators. And so I agree with Pam, and I think Pam, you pivoted well, because the whole number one, copay assistance is important. Number two, copay accumulators are now getting in the way of that copay assistance, and we have to continue to fight that. But now what was on top of it is that the federal government in this rule said, manufacturers, you have to ensure that that copay assistance is going to the patients and not to the insurers. And if you, and the key word was that you, the drug manufacturers, have to ensure. And with copay accumulators, they can't do that, they said. And so so it would impact the best price for Medicaid. You would have to subtract that. You would have to, that would impact all rebates. And so the companies were judging, what's our economic decision here? Should we offer the copay assistance or not? So what the judge did is said, we agree with you, drug companies. The federal government cannot make you ensure that this is copay assistance is going to the patient because of copay accumulators. So I saw that in one paragraph, but I just wanted to put it in layman's terms. That's what we were looking for, and if we weren't here today asking for celebrating this decision, we would have been asking the federal government to delay or withdraw this rule. And we still may have to do that if the government appeals.
So it sounds like this is a win for patients and for copay assistance for patients, which I think all of our speakers have shown us in very clear terms with their slides, that this is absolutely necessary to ensure that patients have access to their prescription drugs. And without them, we see, increasing debt, people making very unfortunate and financially risky decisions in order to pay off their medical bills. And we also see lack of adherence on the part of patients because they just can't afford their medications. So this is good news for now, and we will hope that it sticks. And I'm sure all of us on the call will be very focused on ensuring that that this decision is the order of the day, and we hope we can work with the government to make sure that they're being fair to patients and understand what a bind this rule has put patients in. So I am going to go to another question. Let me ask our panelists, what are the difference between copay coupons and copay assistance? I'm going to ask a multiple question and ask different panelists to jump in. Does this rule, if it were to have gone into effect, does this rule impact a specific type of patient assistance? And then we can talk about, and maybe we have already, but I'll throw it out there. What are the ripple effects of patients losing access to copay assistance programs? So let's start with the first two. What are the differences between copay coupons and copay assistance? And does this rule have an impact on specific types of patient assistance? And I'm going to ask Pam, can you jump in on that? And then Carl, and maybe we can ask our first two speakers to address those questions.
Sure. I think I wouldn't get too tripped up on the difference between copay coupon and copay assistance. It can be, a coupon could be a set dollar amount, think a little bit like a grocery store coupon, $5 off, or it could be something that says that the drug itself is only $5. I think generally what I would say is a coupon is a type of copay assistance. Maybe that's the taxonomy of that. This rule was particularly directed on copay assistance provided by pharmaceutical manufacturers, so that it did not address private nonprofit copay foundation organizations. This was specifically directed at manufacturers. Carl, do you want to jump in? That's what I said.
I agree. And it doesn't matter. It's only those drugs that have copay assistance are affected. So it's not one specific therapeutic class or another. It's just blanket.
To follow up on that, I think one of the points you made, Carl, is critically important, and that is that the patient population that you represent doesn't have access to generics, or when they do have access to generics, those generic versions or biosimilars are very expensive. And so this copay assistance is critically important for them to get access to those medications. And without it, we've seen what it does in Pam's slides to families, to the decisions people have to make in order to afford their care. You sort of reinforce how that works and how they're really, I think there's the misconception that this is a way to get payments into the pockets of pharma companies for brand name drugs, when in fact, we're really talking about a very vulnerable patient populations who don't have access to the generic or biosimilars. And if they do, those are even very expensive.
Sally, I can't add anything to what you said. You just said everything, I think. I think, you said it. These aren't, we have generic for PrEP right now, which is for, prevention of HIV. But for the treatment of HIV, yes, there's some older drugs that are generic, but maybe remember, in the old days, it used to be, multiple drugs for HIV. And then they came up with combination therapies and 3 or 4 drugs in one. And so maybe there could be a generic of one of those components, but do we want to start people, do we want to go back to those old days when you want to have a higher pill burden and you have to take one drug at this time and another time? Really for therapy and the newer therapies, it definitely are brand name drugs, and you wouldn't want to put people on these older drugs that they have higher side effects, higher resistance. And now we have long acting, HIV treatment drugs and prevention as well. So yeah, people just need help to afford them.
And Pam, will you comment on this issue in terms of access to drugs and that this is not focused on or that the patient population you serve needs this assistance because many times there aren't generic alternatives, biosimilar alternatives?
Yeah, I mean, I think much like Carl's space, there aren't a ton of generic medicines across cancers, particularly in the therapeutic space. There's been a lot of innovation, and that is the kind of therapy that my patients need copay assistance to be able to afford. I will say, industry is not allowed to provide support to patients on government-sponsored programs. So think about Medicare and cancer patients for a second. And yet, through this issue, I was able to learn about there are a large number of cancer patients who don't have Medicare as their insurance. They're not on Medicaid either. They need access to these, to this assistance to be able to afford these life-saving therapies. And I would say too, not to get into the weeds, but there has been a little bit of an experiment in California around being able to not use copay assistance for drugs that have generics. And there hasn't been this uprise in generic utilization in California. So I think it really does drive to the fact that a lot of this assistance is directed at novel therapies where there won't be, generics or biosimilars for very many years.
Okay. Yes, thank you for that. Mark or Margaret, do you want to add anything? Not hearing from you. I do have another question I wanted to ask, and I think was probably more pressing before we heard about this decision, but it's still a pressing matter, and that is, has CMS or the Biden administration expressed a willingness to engage in a dialogue about the best price rule?
So from the outside, we have not really seen the interest to drive this conversation, but I would obviously defer to fellow panelists here to see kind of.
Yeah, I did meet with the White House domestic policy staff on this issue, along with some other patient groups. So they're very aware of it. And obviously, since it's been in the court, they're also been aware of it.
Okay, well, I hope those efforts to engage in that dialogue continue. And along those lines, what do we think is the best way for advocates to communicate about the patient impact and patient concerns of the CMS best price rule? And who should they be reaching out to if people want to engage in advocacy and represent some of the disease groups that are on this call and want to be able to express concerns along the lines of what our patient advocates have described, I think, so vividly with their slides.
Well, I do think it's important for CMS leadership, to understand this role, the impact on patients. And but as Pam pivoted, copay assistants and copay accumulators, they're the ones who can make a decision and say no more copay accumulators. And we still would like that to happen. So I would encourage people to talk to the leadership at HHS, particularly CMS.
That sounds good. Before I do want to jump in and recognize Colette Koulianos from the National Hemophilia Foundation for a brief announcement of the sign-on letter she's leading, which is part of our advocacy, our interest in advocacy. Colette, do you want to jump in? Colette, are you there? There we go.
Sorry, yes, thank you. Actually, I was sitting here with bated breath when you got to Mark make the announcement. It was like watching the World News Tonight when some breaking story comes in and you got to say there was a breaking story. But yeah, the All Copays Count Coalition actually has drafted a sign-on letter that we were going to start circulating around this week, asking for those interested to sign on, a letter to CMS asking them to remove this provision. However, I think the feedback we're getting is sit tight on that right now. It looks like for now it's halted, but I think we're going to pivot and turn this into, revisiting the cost, the copay accumulator and the patient out of pocket. And so you will be seeing a sign-on letter that will draft circulate, and hopefully people will agree to sign on and participate. Thank you.
Thank you so much, Colette. I am going to, I think we've hit our time limit, so I think we're going to wrap up, but there's much food for thought here and action steps I think we can take in light of what we've heard today. So let me just thank everyone, our panelists, you were great. And I want to thank all of our attendees at this event. We hope you found the program invaluable. I certainly did, and we encourage you to get involved with the National Consumers League on this issue because we're going to continue to evolve in the coming days, especially in light of this decision. I think we have to continue raising these concerns. They're not going to go away, and engaging with this administration. We'll be making more information available about the best price rule on nclnet.org. And, really, it's all about patients. It's all about patient adherence. It's all about ensuring that patients do not have to go into bankruptcy in order to get access to life-saving drugs, and that's got to be our focus. It's certainly, I think, what everybody on this panel is all about. But thanks again to everyone. That concludes our program today. Take care, and please remain engaged. Thanks, everybody.